Thank you and welcome. So without further ado, I wanted to start off by saying that as you notice between Allison and I talking, that West Virginia is a very diverse state. So yes, we are both born and raised in West Virginia, and we were both born and raised only about an hour apart from each other, actually. So I'm in the Charleston area, and she's in Logan County, West Virginia, which is south of west of Charleston, about an hour or so. And if you could tell by the difference in our voice, that's how diverse our culture is. So if you even go up north, in West Virginia, like up in the northern panhandle and stuff, they don't know what grits are. And if you're a southerner part with, Appalachian, what they think is Appalachian grits are like the inside parts of corn, and they're really good. And they usually put cheese and butter and yummy stuff. But if you go in the northern part of our state, they will look at you funny if you order grits. I know, I've been there. So with that, that talks about how our state is so different. So in some areas we have farming, believe it or not. We have some areas that have no internet because we have the Green Bank facility there, which is a government facility that has all those huge telescopes and such. We have FBI places here. We have coal mining here. We have poverty here. We have universities here. So it's very, very diverse. And depending where you are in the state, literally an hour away can make a complete difference. And so taking into that consideration, we had to do other things um, to make things work because we were so diverse. So we know that every aspect let's see here, there we go. Every aspect impacts mental health. Let me see if I can, there. So we know that all these things, I'm a visual person, so you'll see some pictures through here, that for a student particularly, that the staff in the building makes a difference from one teacher to another, the building itself, the policies in place of who can be educated where, the building curriculum, what's being taught. And again, it could vary from where you are depending upon morals and values and beliefs of that community. And their services are kind of scattered and stuff in places. So where things were more diverse and accepting of different culture, you might have more services. Or if you're in a university town, for example, you might have more services because the university's there. Then some of the other areas, you might have to drive an hour or two. And if you don't have transportation, or the only transportation you have is going to the person who works in the house. So it was barriers. And we knew that all impacted mental health. So we started, and on the left, you'll see the Bureau of Behavioral Health, and this is where Allison and I are. Our story kind of began with that we wanted to reach every student and family across the state and stakeholders, and that's a broad category that basically is everybody else. The schools, the communities, the churches, everybody, all the other stakeholders in that student's life. They wanted to reach every student, family across the state. We wanted to focus on funding and research to evidence-based practice. They wanted to focus on funding on supporting people and actually services, implementing them. We wanted to use data and do strategic planning. They wanted to utilize community input and reimbursement for services. So they're trying to find ways we need to use the community and pay them. We looked at whole child family approaches, and they were starting to look at whole child and family approaches with limited capacity, particularly for those who are going to school. The school can't reach beyond the building sometimes. We wanted buy-in and support from state legislation because we know that also runs to policy and legislation and funding. So we really kind of had the shared goals. We had the same focus-ish with a different lens, but we realized that we really kind of had to start looking together, that actually if we put their brains with our brains and start talking together, we can reach all the goals on both sides of things. And so it's a shared responsibility. Looking at that, we had to look, I'm a picture person again. So the individual is the person at the bottom. And we know that all these things impact the individual, from their home and safety net, the family, the school, the community, and society. And for anything to be stable and lasting in the community, had to start looking through all of these lenses kind of at the same time. But with the people that were specialties in those areas coming together at the table. So we knew that a cross systems approach was going to work. This was just kind of what that last one was talking about, that we knew that it was critical to support our students to improve not only their emotional and behavioral health, but also the academic success. So we started introducing to all these different stakeholders and exploring these the schools and communities working together for education, that a multi-tiered system of support for students is needed, and that can connect students and home and community all in itself. That we needed policies that drove this, and it made the multi-systems that add the thing that we all can get along and work together. And then we need fiscal stringency to make sure that, because the money was being diverted, but if we converge not only our thoughts and our brainstorming, but converge our funding, boy, what change we could make. So this is kind of, we went from a siloed approach to what we call the multi-tiered systems of support, or the MTSS, which is a national model. And we actually had some training come in and work with all the stakeholders in different parts. So I'll get into who all the stakeholders are in a minute. But you know how traditional siloed, and we were there. We're still there in some areas, but we're changing and moving to this other area. So each school has their own plan with mental health or their service agency. So if you are the behavioral health in their community, that's where you're going. If they like it, that's where they go. If they don't, they're not going to refer you. School personnel work in isolation, and they try to do school mental health there. So you have teachers, dealing with kids that are really having some trauma issues and trying to teach academics. There was no data that was used or really available to start to select something. It's kind of a patch meal thing. It's like, try this program. I heard that one's going to work. And the only data that was really collected was the number of students who got therapy or accessed mental health services outside, because that needed to be in the file. So reframing it and looking at it from this interconnected systems within, this system MTSS, is that we developed a clear plan at the district level which is for us, our districts, there's each county in West Virginia. There's 55 counties. So there's 55 districts if you use this language. And so that we went to all of them and said, we need to integrate our mental health and the other services at the buildings. In the school, and involve the community data where that school is located. We need to have a clinician placed in a school and 1 or more days a week to provide services, direct services to those students that need to drive an hour to get to therapy, which could lead in a day loss of work for the parents. Teams at all 3 tiers, and I'll get into the tiers in a minute, include the mental health professional. The teachers are pulled into this, and they're aware what the students are working on, and it's part of their classroom work, as well as their peer work, as well as their therapy work if needed. There's a blended team of school and community providers that work together, that come together, meet. And we moved from just access, like, we got to find these things, to, are these things working? And if they're not, now we have the data to show for it, and we can make change in other ways. The team as process is used, and we select as a team that's mental health interventions. We also select those monitoring approaches and how we're going to align those interventions regardless of who's doing the intervention. So if I don't show up for work today, it continues without me. So as anything, everything's based on data. So I'm going to read the big part. Outcomes-based prevention relies on epidemiological data for success, beginning with assessments of the negative outcomes or consequences of substance use and mental, emotional, and behavioral disorders, and developing an understanding of the factors that cause or contribute to these outcomes. So we pulled data from just about everywhere we possibly could, and some other rocks that we found. Everyone's collecting it. And we just said, let's bring it all to the table and look at it. And West Virginia had an opioid crisis. So we have all this other data that we could pull into this and directly correlate with the trauma that our families were continuing to have because of just the opioid use. So I'm going to let Allison talk a little bit about our strategic plan. We did a prevention.
As Cari had stated and explained, in the past we had a shared goal, but we were not working together. West Virginia has tried to pull together all the stakeholders to come up with a prevention strategic plan that we've been working on for the last 5 years, and we identified their long-term and short-term goals to reach our outcomes, but it's all based again on the data, as Cari had explained. Our first goal in West Virginia was to increase, sustain, and align investments in in prevention, including strengthening our prevention workforce and advocating for policy reform. And a good example of that is, underage smokers. The state worked to increase the smoking age, and of course that become across the state that we gradually put those things in place. We provided funding prevention that was increased through a dedicated line budget. We also come up with a professional prevention association that serves as a clearinghouse, and on that clearinghouse we have different steering teams that we meet regularly to discuss the goals and the objectives and what we need to move forward. Our second goal that we put in place was maximize cross-systems planning, collaboration, and integration. And we provide evidence-based programs and indicators in the community as well as the schools. We have recognition at local levels that prevention works and aligns and interfaces across multiple levels. We try to identify the gaps and the lessons learned that we can share and build upon. We have external and internal communications across partners that can be enhanced. We have local planning efforts that we build upon. We have an infrastructure that is created to reduce the silos by working individually to increase the community collaboration and the school collaborations and the other stakeholders that we want to pull to the table. Goal 3 is to improve data collection, integration, and use at the regional level to track progress and promote shared accountability. Again, we rely heavily upon the data. We want to make sure that the data will inform and improve the quality, the policy and changes and decisions. And the data, we try to share the data with all the stakeholders involved. We aligned a strategic communication and awareness for education. We have long-term expected results with achievement and outcomes that we hope to accomplish. But it's real important when you develop your strategic plan that you identify, again, your long-term and your short-term goals. I don't want to read all of these to you because you can go back through the slide. When we come down to the prevention strategic model, we decided that, based on our data, we need to do, the first thing that we need to do is assess. And when we assess, that means that we look at, we do readiness assessments, we do needs assessments, and we pull from there the starting point. What is the problem? What do we need to work on? And then we look at capacity. We build on our local resources that we have in the community. What's working in the community? What's not working? What can we do to help the communities to put other things in place? Then we do the planning. We find out what works to address prevention needs and how we do it. Then we've tried to do the implementation piece of getting things out to the community. What do we need to put in practice? And that's where we started putting the evidence-based practice programs into the schools. We have put out through our stakeholders. And then we go from there to the evaluation. Evaluation, is the plan working? Is it succeeding? How do we examine the process of the outcomes and the programs and the practices? Within the children's programs, again, with prevention, we've tried to bring together all the stakeholders to work together. It really takes a community to be involved to make the changes. I know way back when I first started in the school system, there was a saying that it takes a community to raise a child, but it really does take a community to make a difference. We have external supports that's in place. We have 6 regional lead prevention organizations. Our state is divided into 6 regions that we have different supports in each region, and each region may cover 8 to 10 counties. We have Prevent Suicide, West Virginia, with regional intervention specialists. We have expanded school mental health grants. I think as of right now, we're in the 49 schools with an additional 18, and we continue to grow every year.
Did you mute yourself?
No? Can
Hello?
you not hear me? No.
Can everyone mute your mics if you're not speaking? Thank you.
Okay, so I'll take off where she left off. So as she was talking about, this is the slide that I actually slipped over while she was talking. So we have all these programs that 6 regional lead prevention organizations: Prevent Suicide, Expanded School Mental Health, Regional Youth Service Centers, Wraparound, Mobile Crisis, Positive Behavior Support, which is in-home and community services, which is different than Positive Behavior Interventions and Supports, which is down further, family coordinators, transition navigators, community serious emotional disorder waiver, or CSED waiver for those students that are seriously emotionally needs that need that wraparound kind of thing, family resource networks made up for families. And then we started putting this outside stakeholders like the community behavioral health providers, the school-based health centers, because we were starting to get those, you know, the dentistry and a nurse practitioner or so in some of our schools. The Autism Training Center at Marshall University, they were the ones that started the Positive Behavior Support Intervention supports, and that's school-wide. We also had Marshall University Technical Center, which provides wonderful technical stuff for Department of Rehabilitation Services, and it also begins some professional development opportunities. Allison, are you able to talk?
How about now?
Yes, ma'am.
Can you hear me now?
I can hear you now.
Okay, don't know what happened. Okay, as Cari started off, finished the slide for me, I'll talk about the prevention lead organizations. Again, those are, we have 6 in the state, and they are broke up into our regions again, that we're continuously, again, trying to provide services in each region. With the prevention lead organizations, they are responsible for providing information, dissemination, and that's brochures. It's really one-way communication. It's brochures, it's media, it's speaking engagements, it's health fairs. And again, that's part of where we build the clearinghouse to build upon to help get these things out to the community. They work on education. They help the expanded school mental health with purchasing of evidence-based programs. They work in the classrooms with small group settings. They have peer leaders, helper programs, youth groups will help with the education. We have alternative programs, and that's the Partnerships for Success under our Substance Abuse Block Grant will help with drug-free dances and parties. We have a youth adult leadership programs and community drop-in centers. We have problem ID and referral. If the problem is identified, then they help with doing the referral process. And that's also for students and employees in our school system. Sometimes our employees in the school system are overwhelmed with things that's going on in the school. And so we also try to help the employees with some stress relief and things like that. Then we have community-based processes, and that's where we try to...
Excuse me, but we can't hear her.
Still can't hear me?
You're very low.
Can you speak closer to your microphone?
Well, I took the microphone off because it wasn't working. Okay, how about now?
You're better now.
Okay. The community-based processes is training key people in the system. We have a systematic planning with coordination and review of the policies. And again, that is working in the community and bringing everyone together.
Environmental strategies is product pricing strategies, technical assistance in the communities, improving the environment to make it safer. Under the PLOs is the Partnership for Success coordinators who work on selective and indicated evidence-based programs. And again, some of those evidence-based programs are through the Substance Abuse Block Grant, and they're county coalition workers to assist in providing the services with selective and indicated. The next slide, we'll talk about our suicide prevention, and I'll just go over some of the supports that we have available in the community. And again, it's a system that brings all of the services together to work as a whole instead of individual. We have suicide prevention that's in West Virginia, and it provides a wide array of services to a lifespan of populations. And basically, we want to produce a statewide infrastructure for culturally competency and caring, comprehensive, sustainable suicide prevention, intervention, and follow-up care of system. We have substance misuse prevention work, which is developed under the prevention infrastructure.
I'm so sorry to interrupt. We really can't hear, and I'm just concerned we're missing a lot of great information. Is it possible to turn your volume up on your laptop, maybe?
Honey, it's all the way up. Cari, you may have to take off.
I'm so sorry
it's okay,
to interrupt you.
She was doing so good, though.
Allison, have
Yes.
you tried calling in and using the phone?
I haven't.
That might work better. What you would need to do is put yourself on mute here, go over to the mute button, and there's a little arrow by the mute, and it'll tell you how to call in.
And I'll start talking while you do that.
Sorry.
Oh, it's okay. No, I know this stuff too. I get excited about it too. So the suicide prevention, as she was talking about, is really kind of across systems. Again, we have everything from training that is for providers. We have first aid, mental health first aid. We do the expert screenings for all the students. We have suicide prevention in every school, and that's a tier 1, whole school activities actually written in our laws and policies. We have youth interventionists that will respond if there's a problem in a situation in a school with an attempt or an completion, and they work with the students, and we use evidence-based curriculum. And for postvention, prevention, there's a crisis line. There's it's just a wonderful thing. They do all kinds of work in the community with Out of the Darkness work on the national level. In our community, you might see some of those walks and races and stuff. But it's really ingrained in our community because we were seeing a high rate of suicide due to opioids. So the framework that, the prevention framework that Allison was referring to was the PLOs, the prevention lead organizations. And these are really part of the big infrastructure that kind of makes the boots to the pavement kind of work on another level. So there's 6 regional ones. We broke our state up into 6 areas, and they have many counties under each area. And under those regions, there's county coalitions. And those county coalitions are the ones that work with their direct communities and provide resource mapping and information and data and what their communities need. The Partnership for Success coordinators, which Allison had alluded to, the State Opioid Response Coalition Engagement Specialists, the SOR, or State Opioid Response Adult Suicide and Intervention Specialist, the Garrett Lee Smith Suicide Intervention Specialist, Prevent Suicide West Virginia. So all these things, we all started coming to the table together and making these. So part of that was also the school system, because that's where our students live 40 hours a week plus, if they don't have extracurricular activities. So we found that was a place to get not only services to the students, but a place for the parents to be too, where they can get things. So they don't have to take a day off work and find somebody to drive them to a therapy appointment. So expanded school mental health actually refers to the programs that build on the core services that are typically provided by the schools. It's a 3-tiered framework that includes a full continuum of mental health services. And we'll get into more detail as the slides go on. So it starts with a basic idea that services and supports need to be for all students. It's not just what we call those tier 3 students or the ones that need therapy. We've been putting out fires for years and it doesn't work. We have to catch them before they get in the water, teach them how to swim and put on a life jacket before they get in the water. So it's all students, and it crosses disability as well. We knew that the schools were a critical link between the mental health and academic success. We knew that all three of those things, for academic success and school success, you need mental health success. And all three of those have to work in tandem with that safe environment as well as the mental health. It's a whole child approach. We knew that there was need to be a shared responsibility between the schools and the community providers. Before, it was a state coming down to each community school system and saying, thou shalt, this is what you need to do. And as I alluded to earlier, we're a very diverse state. There's one county that has a high population of Spanish speaking Americans. And they're coming into middle school and their English is not as good. So what do you do with that? So that was something that school needs to address. So how do we pull those families in? How do we, get those students to start seeing peers? And how can we teach the students and everybody Spanish and English and facilitate that? Because that was a community there. We wanted to have meaningful involvement of the parents and youth and honor their cultural competency, where they came from and who they were. Like, again, we're very diverse here. We wanted to use evidence-based stuff and best practices stuff. We wanted to do something that's research-based instead of just throwing Band-Aids at it. And we also wanted to continuously look at the quality improvement, that it's a moving, living thing. So me and my pictures again, this is how the ESMH became like a collaborative project. So there's an overall steering team that's made up of a technical assistance team from Marshall, and they go into a lot of the training, evidence-based practices. They work on the website that you've seen there. They are pretty much like a specialist in all things school-based mental health, evidence-based practices and such, and capacity building. They're a licensed therapist as well. Then we have the Department of Education, and this is the State Department of Education. We have county boards and then the state department. So we're very heavy on the administration. So with that support, they all came together, and we have stakeholder, we have community behavioral health people on there. We have teachers in there. We have parents in there. We have an FRN, which is a family resource person in there. We have positive behavior support people in there. We just have all these people that on this steering team come together and, find what the best practices is and try to meet those gaps in our state. So one of the things that we really wanted to do, and we found out, with this collaboration, that we needed a consistent, systematic referral system for all kids across the state, because kids were getting lost. If you move from one county to another county, you may be lost. They wouldn't get you may get their school records, you may get their mental health records, you may not, And so we needed a way to not lose these kids anymore. We needed to have mental health crisis plans, for everyone, instead of everybody always being in crisis. We just needed to accept it and say, okay, how are we going to deal with this capacity now? We needed to change those parent-teacher consultations to be meaningful instead of Johnny's in trouble. We wanted to have really good consultations with our school staff that included parents and the community professionals. If you're in the school, I used to work more outside of the school. Allison was more in the school. So I was the outside person coming in. I was that community person. And in some places, you're not from here, you're not coming in. And I appreciated that, but that didn't help me. Appreciating to get me in the community. So that relationship needed to be built. We want to follow up and collaborate with community partners. One of the things that we always saw was that, yeah, I'll do that, and then drop the ball. So we needed to have this continuous follow-up. We want that family engagement at all levels in the systems and programs. We wanted their voice at the table. So ESMH builds from what the schools already have. So each county is, like I said, each county is a district. So each county, then we look at their academic supports. What are they doing there currently? What are the behavior supports that they're using? Are they working? Are they not working? Where are the gaps? What else are you using? What are those collaborations and shared relationships that you already have? Are you using PBIS? Are you using a bullying prevention? Are you using attendance support? So like a pro officer of sorts. Are you using students assistance teams? And these were our disciplinary teams usually. Some of our counties use it that way. What about your IEPs and your Policy 504 students and all those supports that are under those? What are your outreach and linkages in your community? So what do you have? So then we got into the PBIS is in some of our ESMH schools. To me, it's a perfect marriage because PBIS is the complete framework to sit on because it totally relates and changes and the environment of the school. So their focus is to look at, does a student walk in and feel safe? Do they know that there is someone that's trusted they can go to? Do the teachers know the students? They really look into this on that level. So PBIS is integrated in MTSS and multi-systems practices, and it looks at the whole student again. So on tier 1 for them is they look at the whole school culture. How are they talking to the schools? What does the posters look like in the school? One of the things that they do is green dot, which they put a bunch of pictures of every student in the school, no names, just the students in the teachers lounge, and teachers walk around and put a dots by the students that they know. And then they go in and talk about, okay, who are the ones that are missing the dots? Those are the ones we know we have to reach. Restorative justice practices instead of just straight punishment, caring school communities, which is an evidence-based practice. Substance use and suicide prevention and screening needed to happen. Tier 2, the kids need these other outlets. So they create book circles and student clubs and leadership clubs and volunteer clubs, and they go out in the community and stuff. And it involves social emotional skill building. So they can build evidence-based practices around all this. Resilience builder is one we use, and change company journals is another one we see. Tier 3 is that intensive and targeted individuals. Those are your therapy, individual, and family. This is, again, me and my visuals, and Allison has another visual to show you how some of these marry together. So this is kind of the basis of what expanded school mental health is. And then the next one, she'll show you how it applies to everything else. So if you look at tier 1 at the bottom, the big green thing, and that's that every student, environment, school culture. So this would include, if you look at the bottom on the right, it talks about the early warning systems, school-wide student advisory, prevent suicide, the policies and codes. These are all the things that would fit under this tier 1 that every student would get. And then tier 2 are these more targeted things. So your SAT referrals, your comprehensive school stuff, like your crisis intervention. We do it, but we forget. We have a phone tree, and that wasn't good enough. We needed people to call and real stuff to do when our students were having problems. And these could also be small groups to work on resilience building things. Like we have one that I call lovingly the Mean Girls Club. It's actually an evidence-based program. It's not called that, but that's what I call it. And it's for that situation. If I say that, you kind of know what I'm talking about, is what that situation is. And then tier 3 we've always done, which is that tier 3 intensive individual supports. We're just pulling them into the table so we can all talk. So Allison, can we hear you now?
Can you hear me now? Very little.
I can hear you.
I couldn't call in because I had to have a meeting pass word, and I put that in the chat. But the multi-tiered system of support is across the continuum. Can you hear me, Cari?
We can hear you.
Okay, good. Again, as Cari talked about, it's about bringing the community and the school system together, and all the supports within the community. We worked on a 3-tiered system that was selective, targeted, and universal. At the universal level in the community and the school system, we work with everybody involved. Every student across the school receives evidence-based programs, and then we provide the community with our EBP programs. That's through the prevention lead organizations. With the targeted group, it's the same thing. In expanded school mental health, we had to provide tier 1 and tier 2 services, EBPs, to the students, to a select amount of students. It's students that's indicated whether they've had an issue or if they've had a problem. Same thing in the community. If we identify that maybe underage drinking has become an issue, then we try to flood both the school system and the community with evidence-based programs. In selective, again, that's where we look at, are kids at risk of losing their home? Do they need therapy? In the school system, are they having behavioral issues? Do they need maybe, instead of just some counseling, do they need intensive therapy? So again, we try to provide those services at that level. We have school-based mental health centers that is now in place in every school in the county, in all of their counties, and any new school that is built. I know we are providing school-based clinics. The clinics will offer dental services. They offer services sometimes to the family and the student. They're able to bill insurance or whatever means of payment that the student may have or the family may have. They provide preventive and intermediate care, behavioral health services, health education, and sometimes even the dental care. It's provided during the day. They're not open during after hours. Referrals to other health providers can be made through the school-based mental health clinics, school-based health clinics. Moving forward, we want to try to align all of the school social, emotional, behavioral initiatives through one system at a state and regional, district, and school levels through the multi-tiered system of support. We advocate for active participation in family use in a central location. We structure and process for education and mental health systems to interact in most effective and efficient ways. And again, we try to bring in all the stakeholders, the law enforcement, the health department, our behavioral health comprehensive centers, our school-based clinics, our teachers, our school boards, anybody that could have an impact on the student or the family's life. We try to bring everyone to the table to do that. Cari?
Yes, ma'am. I had to find my mute button again. So we also started building really effective teams that included those community mental health providers. So not to leave our mental health providers out there providing therapy outside of school into the family. We needed to start pulling them to the table so there was not a disjoint. We started making really good database decision making, and we include school data and not just daily office referrals, but also, like I was speaking about, the resource mapping is a map that that comes off the prevention side of things. It tells what's in the community, and it also does a thing like who has been thought about drinking in the 7th to 8th graders in the past 30 days, who's used, who's living with their families, who's in state custody, who's just really in-depth information for that community specifically, so we can pull that out. And we had formal process for selecting and implementing evidence-based practices across the tiers with a team decision instead of just somebody coming in and saying, do this. This allows for early access to the use of comprehensive screening because it's built into that tier 1 and tier 2. Utilizes that internalizing and externalizing needs, so it's all like one stop. We started doing rigorous progress monitoring because if it's not going to work, we need to pitch it, and we need to find that, something else. So we also want for fidelity. So how is it being implemented, and is it being effective with this population, and is it all the interventions that we need, and is it across people? So if I'm gone one day and the next person, is that fidelity still there? We wanted to provide ongoing coaching, both at the systems and the practice level for both the school and the community and the professionals to make sure that it was crossing over.
The regional youth service centers is design and purpose of the center is to coordinate a spectrum of community-based services to provide partnerships and families with the youth with the goal of improving youth functioning in the home and school and community. The components of the Youth Service Center is a full continuum of care, community-based treatment and services, referral and outreach, and engagement with diagnostic and outpatient clinics. The Children's Mental Health Wraparound is an initiative that we took from the National Wraparound West Virginia Safe at Home program. It's evidence-based and it's modeled after the National Wraparound program. It's individual strength-based focus, trauma-focused planning and intensive intervention delivered in a community-based setting. It serves to support the needs in parental custody and those who are at risk of being placed out of custody.
So Children's Mobile Crisis Response and stabilization teams, we had some kids that were always ending up in, not always, ending up in the juvenile justice system for behavior that was not criminal behavior. It was trauma response, or it was abuse, neglect, or it was a mental health issue. So that was not the place to end up for them. So we came up with another way to intervene. So this isn't regional across the, and it's regional across the state, and there's different behavioral health centers and comprehensives that run this. And it's really, there's a 24/7 crisis line, and so you were calling your local person in your local community, and the crisis is defined by the parent or the family that's experiencing it, and they go either by phone or literally in person if needed to be, with assisting that family and that youth that experiencing an emotional or behavioral crisis, and they interrupt it with immediate crisis planning and providing the safe and supported stuff. So you have a therapist and a caseworker kind of person that's there instead of, you know, just the police officer or a police officer. So it also supports the need for children and to families to, after a crisis occurs, to get back to the routine as quick as possible, so that the children are maintaining in their home, and they're in their, you know, they're not disrupted more than they have to be, because before they've been coding off the jail, could be there for 60, 90 days before they were able to get out because they were stuck in the system. So this also links the children and their caregivers right there on the spot to other services in the community they'd be lacking. So it can be food, it could be shelter, it could be anything. And so they also get them treatment, and it also keeps those students ending up in a hospitalization for something when the parents just may need a break. So this kind of ends up into can lead into a crisis intervention and stabilization up to 72 hours. So if it's to the point where the child needs to be removed, so to speak, or it's really a break, and it's a 72-hour break, and it's a respite quick thing, it's a local thing, they're not found in a bed. And then from that, they also pass them with a warm handoff to start doing usually to a wraparound program of some sort, to transition plan and to follow up so they're not lost again, to maintain that home. The FAST is a legal system that's been around for a while, and it stands for the Family Advocacy Support and Training, FAST. And this is a statewide parent and youth network, and engages families in the planning and management of their child's mental health or service needs. And they have attorneys and paralegals. So this is kind of their bailiwick, and it's free to anyone in the state of West Virginia. And they can work with families with IEPs. They can work with families to facilitate discussions between school or community behavioral health centers when they're experiencing problems for accommodations or need a different behavior plan. They can help actually resolve some legal concerns that have to do with custody and adoption, or getting benefits, or transportation and housing. And of course, they're always there for linkage referrals for anything else in the community. They're another hub. They can assist with transition between schools and school districts. So when a student moves from one place to another, they're not lost. They're still plugged in. Identifying the supports to prevent dropout and truancy and all those things. They're really just a wonderful resource, and they do training and everything as well.
The Family Coordinators is a system of care values. It's family-driven and youth-guided. With the strengths and needs of the child and the family determine the types and the mixes of services that the supports are provided. It's community-based. It's culturally and linguistically competent, with agencies and programs and services that reflect the culture, the racial, the ethnic, and linguistic differences of the populations that serve to facilitate access and utilization of the appropriate services and supports to eliminate disparities in the care. It promotes coordination and integration of family-centered care. It facilitates participation and involvement of the entire family in treatment and recovery of a child, a youth, or adult. It connects families affected by mental health and co-occurring disorders with supports and resources within the community. It facilitates the needs of the family members of the children, youth, and young adults involved in the services at the regional service centers and those who have been referred by other community agencies. They assist families in system navigation. They help them with referrals to other behavioral health agencies or the clinics that they may need services from. They develop a plan to engage more families in a systematic and programmatic development of improvement, recognizing the family as an expert. They really foster the ideal that we want to strengthen the families to become their own advocates for them to be able to navigate the system, for them to be able to utilize to get the services that they need within the community. They develop and execute a social marketing plan to promote services for families in the community. They refer families or individual family members to appropriate support groups and assist in forming a family-led support group if needed. The first episode psychosis service is a youth service system, offers a best practice designed to address early serious mental illnesses. It's the first episode of psychosis. The program is at our youth service centers, and it's called Quiet Minds. The purpose is through the model known as coordinated specialty care, and there's an emphasis on outreach, community, assessment, treatment, supported employment, education, health promotion, and advocacy. The goal is to facilitate the early identification and treatment of psychosis in a collaborative, recovery-oriented approach involving individuals experiencing first psychosis. Therefore, we want to reduce the disruption to the youth functioning and psychological development.
So CHOP, the Children's Homeless Outreach Program, is a secure, healthy environment. It provides case management, life skills education, brief counseling, referrals, linkage to community services, and supports for children and their families who are experiencing homelessness, and they're residing in one of our shelters. The 8 out of 10 West Virginia's homeless shelters have served families and their children. So the intent of the program is to assist to kind of screen those children and families and catch them there. So we assist the homeless children and adolescents at risk for serious emotional disturbances. So there's some screening there. Their families transition from the situation from homelessness to stability, housing as soon as possible. So they have people there and caseworkers. They refer and link behavioral health services and other community supports. They focus on the students and make sure that they're not lost. They assist in recovery from and prevention of future homelessness. So they have evidence-based programming there that they provide for the families. There's a parent side of it, and there's a student, a child side of it. So the big thing that the takeaway that I had for a lot of this, it was we had a lot of work to do, and this is just touching on the tip of the iceberg of how we got this together. And so really it comes down to teaming. It's teaming on every level. It's teaming on the grand level, on a state level. It's teaming in those districts, it's in those school boards, and even in the schools themselves, all the way down from the macro down to the micro. So this is what we've come away with so far that we've learned, is that every member needs to understand the mission and the vision and the purpose of the meeting. Not only the big goal of what you're trying to go, but why am I here? Why am I sitting in this meetings, which usually leads to something like an agenda or a format to run your meeting. We also learned that every member needs to understand the role of each team member and think how to use their roles and use the other person's resources instead of just like, this is the teacher. Well, what does this teacher have access to? Well, she has a best friend who runs the 4-H group. Can we get that 4-H group involved? We had one school in the southern part of the state that uses Red Hat Society. These are the kind of things that they need to start thinking outside the box and bigger for. Every member is an active member for all decisions. So everybody has a voice at the table, and that has to be with how they implement too and how they develop it. One school may be able to have readiness to be able to take it and run with this, and get it up and running within a month. We call those, super performers because they're your type A people. And then you have other schools that you have to do a lot of readiness first. You have to get buy-in first. You have to wait for this assessment to be done. And so you have to listen to this. Every member understands that process and can't push it. You have to listen to each other. Team is not the highest ranking person in the room. So the way we used to do things, that when your director or deputy, whatever, would sit in the room, is you weren't allowed to talk because you were outranked. That's not the goal. Everybody's goal are the students and their families and the community. The team communicates openly, honestly, and quickly when barriers arise. And so there's that junior high stuff can't work. We can't be talking about so-and-so. That doesn't work for the goal. So that takes issue. If you have an issue with a barrier that's true, without calling out names specifically, take that issue to the team for brainstorming and problem solving. So then that strengthens that team, because that is the core of everything. Nothing else is going to work if you don't have everybody else working with their arrows pointed the same way. They need to meet frequently. It could be brief, but frequently to track all aspects of implementation, because that way you can address barriers quickly and you can change things quickly, and you can, oh, is that all you needed was room to go to there? Then, oh, I can get that for you. It's just easier to do. People want to meet quarterly and tackle all the stuff. And it isn't a running, moving thing. So the last slide I have is just our contact information. I'll leave that up for just a minute at the top. Well, maybe if I can get my thing. You'll see the DHHR website where BBH, where Allison and I are.
Also, Cari, I shared the Help and Hope website that will explain all the services that West Virginia offers through the children's program.
Okay, yeah. So it's 4:22. That means we have about 8 minutes or so for questions. If you want to unmic or place in the chat. So with the system of care, I noticed in the chat, speaking of the system of care, West Virginia, like many states, until you get, part of moving from that silo approach into the thing is we're losing kids, when they go from one community center to another, one county to another, from one job to another, that we're losing kids. So part of that system is care is we're making one depository for information. One depository. So if you are receiving this service at this school, it follows you wherever you go, and you don't have to wait for a caseworker to dig in the file or go into archives because I was in, this county 20 years ago and stuff. It's going to be more accessible. We had to do a lot of brainstorming and talking about HIPAA and FERPA and all the other IRPAs for security and stuff, and work how to do it. And so we've had to work through legislation and some other things too to get it done. But to me, that's exciting if we're not losing kids anymore.
Their slide is on the conference website.
Any questions? I'll be quiet. I'll do my therapist quiet part.
So this is Mrs. Hernandez from Connecticut, but I love the program that you guys have there because it's in the school system where the kids really need the benefit and support of it. I wish we had, state by state, a program that fits all so that we can, benefit from it, from what's working, what's not. But I know when our kids move from district to district, something gets lost. So yeah. I like the idea of you guys regionalizing it and connecting them and not dropping the ball on them. Because it's what frustrates families the most is when people change, the routines change, the therapeutic people change. It's really hard for our kids to interact again. So that's a good thing.
Right. So how many times do you have to tell your story, over and over and over again? How many families are coming in with all the strangers coming in with the name of help, and we do really mean to help, but that in itself can be traumatizing. And you're absolutely right. So trauma informed is language that we use here as well. We want that in mind. And so we look at everything through the trauma lens. What else could be causing trauma? Well, this child just went from foster care to this, to that, to the, okay, we have at least 5 instances, not to, just the moving alone, let alone everything else they impacted. And it goes all the way out through the community, it's not just getting it in school, but they show up at ball games, it's in the community as well.
And I think our expanded school mental health school sites are dealing with the same thing with staff turnover, staff shortages. It's kind of a crisis at some schools because they don't have the people to provide the services.
North Carolina is supporting system of care and working to address every system across 100 counties. Wow. I thought 55 was a lot. 100 is a lot. Yeah, it's a lot of coordination and buy-in at the state level. We had some legislators that were, approached by constituents across the state and with this evidence-based kind of stuff. And so that also had to be in the work as well, to have that kind of support from, I'm not saying that we're funded wonderfully across the board, but we're able to gather the data and say this is working. And so then the funding, comes in after that as well. So we have about 5 minutes. Well, thank you guys so much for sticking in with us for the last hour of of the conference on a Saturday. I hope the weather is beautiful where you are. The conference slides will be available on the website for the National Families Federation of Families and available for 90 days for you also to view this recording. Feel free to reach out to Allison or myself, visit the Expanded School website for West Virginia and or the VBH website. And if you want to learn more, we're here.
Thank you, everyone.
Thank you.
Thank you, guys.
Goodbye.
Thank you.
Thank you.
Thank you.